Hello, everyone, and welcome to our program on a holistic approach to diabetic peripheral neuropathy. On behalf of the Foundation for Peripheral Neuropathy, I wanted to extend my deepest appreciation and thanks to today's sponsor, Veritas. My name is Lindsay Colbert. I'm the Executive Director of the Foundation for Peripheral Neuropathy. I will be moderating today's panel, and I'm so excited to get this program started. Today, we will feature a panel of 4 experts in the field of neurology, integrative medicine, acupuncture, and nutrition and physical therapy. Following the presentations of our subject matter experts, I will moderate a Q&A session to conclude today's program. As we pride ourselves in offering fact-based and vetted educational programs to our patients, caregivers, and healthcare providers, a recording of today's panel discussion will be housed on the Foundation's website for future reference. At this time, I'm pleased to introduce our experts. Our first panelist is Dr. Mazen Damachki from the Kansas University Medical Center. Dr. Damachki is board certified in neurology, clinical neurophysiology, and neuromuscular medicine. He is currently professor of neurology, director of the neuromuscular division at the Kansas University Medical Center, and director of the Neuromuscular Medicine Fellowship. He is also executive vice chairman of the neurology department and vice chairman for research programs. Our second panelist is Dr. Lori Walsh from the Centers for Health and Integrative Medicine at Advocate Good Shepherd Hospital. Dr. Walsh uses her clinical expertise in integrative medicine with a focus on nutrition and lifestyle, teaching to prevent disease and promote health within the cultural and socioeconomic context of the patient. She sees patients at the Center for Health and Integrative Medicine located in a Chicago suburb and oversees the clinical care provided by the integrative medicine team. Joining Dr. Walsh is our third panelist, Joanna Johnston. Ms. Johnston integrates her experiences as a nurse and an acupuncturist. She firmly believes the combination of Western and Eastern medicine facilitates quicker healing and recovery. She has a bachelor's of nursing as well as a bachelor's of science in nutrition and a master's of science in oriental medicine. And last but not least is our fourth panelist, Mark Fasek. Mr. Fasek has a Bachelor of Science in Physical Therapy and post-professional Master's of Science in Neurologic Physical Therapy. He is board certified as a neurologic specialist. Mark's education and experience provide him with the skills to care for a variety of patient types. However, his expertise is in the area of neurologic physical therapy, treating a variety of neurologic conditions, including stroke, Parkinson's disease, multiple sclerosis, neuropathy, and others. Please join me in welcoming our panelists and thanking them again for sharing their expertise with us today. At this time, I will now pass the virtual mic over to Dr. Damachki, who will kick off our program with his presentation. Thank you again, Dr. Damachki. You're up.
Thank you for this kind introduction. I know this will be a very brief presentation in the interest of time. If I can have the next slide, please. My focus today will be talking about neuropathy in general from a medical management in a way of drug therapy standpoint. However, one has to realize that the management of neuropathy, which is a very common problem, about 10% of the people in the United States have about neuropathy, with a variety of causes, anywhere from diabetes, but there are other less common causes, and about half the time, we don't know the cause for neuropathy. Next slide, please. So when I see patients coming to me with neuropathy, the cause is one of the questions they have on their mind. But the other question that comes up is, what will I do with my pain? And pain is a common complaint in peripheral neuropathy. About half the patients with neuropathy will have some kind of pain. And there are targets for treatment. Of course, you can see here on the right-hand side, the pain scales that we use in the clinic. But in addition to the pain scales, it's important to measure the functional impact of pain on patients, meaning, is the pain interfering with someone's ability to fall asleep and stay asleep? That's important, because if we're sleep deprived, we're going to be more cranky, but at the same time, pain may be less well controlled. The second item to look at is during the daytime. If someone is gainfully employed, is this interfering with their focus on their job? Is it taken away from their ability to do their job? And then finally, it's not all about work and sleep. It's about also doing fun stuff. So is it interfering with activities of daily living? So the first time I see a patient, I emphasize that the focus is not just a pain score, it's a big part of it, but the other big part of it is the interference with the three key domains of sleep, function, as well as recreation. So we use medications typically that are antidepressants, anti-seizure medications. We also like topical agents, especially for patients with localized pain to the feet or the hands. This is an ideal case scenario. And we use drugs oftentimes without FDA label. Next slide, please. This is from a publication that came out recently by the American Academy of Neurology, commenting on some of our pain management using these classes of agents. And I'm not going to go into specific names that much here, except to say that they fall into groups of either sodium channel blockers or antidepressants or of the class of anti-seizure medications. One of the drugs, however, that used to be used quite commonly is called tramadol for pain. But it's become obvious this drug is problematic because it has a high addiction potential. And from studies, it's been shown that the mortality associated with its use is higher than the normal general population mortality. So while it used to be, next slide, please, on the list of medications, what we recommend for neuropathic pain. On the left side, you see oral medication. On the right side, you see topical medications. This is what we recommend sequentially to treat neuropathic pain. Tramadol has been dropped off from that list. Now, this gives you also another perspective. Why do we have so many medication on the list, so many medications on this list for treatment of neuropathic pain? Well, it turns out that none of those work all the time. They work at best 40% of the time. So it's a hit or miss type of a trial and error experimentation process when you're going on a medication to try to modulate pain. Next slide, please. So why not use narcotics, painkillers? It seems to be like the easy answer. And this would be the wrong answer. Let me tell you why. Because there's quite a bit of evidence about the harm of narcotics and little evidence about how good they are for treating chronic nerve pain. Next slide, please. Excuse me. So what other options are there outside narcotics in managing neuropathic pain? There is spinal cord stimulation. This is for diabetic neuropathy. A study was done leading to the FDA approving implanting a spinal cord stimulator for patients with refractory diabetic neuropathy related pain. So this is something that's an added advantage that we have now in the last couple of years in way of management. Next slide, please. The other thing we can do is use a hyper-concentrated capsaicin. Capsaicin is that burning material that you feel when you eat a hot chili pepper that's due to capsaicin. So the normal capsaicin that's over the counter is 0.125%. This is a hyper-concentrated capsaicin patch that's 8%. That's also been approved by the FDA for localized diabetic neuropathy pain. It works, about 40% of the time, like I said earlier on, but it requires reapplication every several months. Next slide, please. So what else do we tell patients with neuropathy in general? Lifestyle modification. You're going to hear about physical therapy and exercise. That's very important as part of the management of neuropathy in general. Good foot care, podiatrist visit, the right shoes, the right socks. Sometimes it's cognitive behavioral therapy or visiting with a psychologist that's specialized in pain. TENS units, acupuncture, biofeedback, all these things are helpful methods. Next slide, please. What's really not been shown to work well are some of those other interventions that have not been shown in research studies to be consistently effective So what I do when I see patients coming to me asking me about questions about getting like pumps of narcotics being implanted, I discourage them from those. Or if they want to have decompression of nerves for the treatment of their neuropathic pain, I caution them about it too. Next slide, please. And the other thing I caution my patients about is those 2-page ads that sometimes use fancy language to try to convince patients to come in to pay out-of-pocket expenses and in interventions that advertise themselves as cures for neuropathy when we know that there's no cure for neuropathy at this point in time. Next slide. So at this point in time, I'll stop here and turn it over to my colleagues for their presentation. But managing from the neuromuscular doctor standpoint, neurologist standpoint, neuropathic pain is complex, multifaceted. We have a lot of drugs, but we always need help from our colleagues that do physical therapy, acupuncture, alternative medicine. So I'm glad we have a good, strong panel joining me here. Thank you for your attention.
Thank you so much. Well, I really enjoyed that part of the talk, and this part will flow right from that. Next slide, please. So I'd like to start by explaining what is integrative medicine, because as we've seen, there are ways that can be presented as something integrative, but it's really a marketing plan, and rather than a evidence-based modality. So the idea is that we would take what we learn as physicians and we take it and expand it using appropriate therapies, both conventional and alternative. And this comes from the Andrew Weil Center for Integrative Medicine. Next slide, please. So here's our center, and this is unique in that we're in a hospital. So it gives us the opportunity to really interface with patients that are ill in the hospital and also with the physicians so that they can understand how we can help partner, because this is really a partnership, and we have a little bit of a different focus, which I'll show you next. Next slide, please. So who benefits from integrative medicine? Pretty much everybody. This is really a way to focus on healthier lifestyle, and we have a team of acupuncturists, massage therapists, yoga, trauma-informed counseling, holistic nursing care, and we go from infant to adult. And you can see on this list that type 2 diabetes or a pain is in there that would work very much in an integrative modality. Next slide, please. So this is how our teams brings together conventional and complementary. So as a trained MD, we have acupuncturists, and you'll meet Joanna in a bit. She's a nurse and an acupuncturist. So we begin to be able to speak the same language, but using different ways to solve a problem. Next slide, please. So this is the wheel of health, as I call it. And we all know this, but what I love about integrative medicine is it allows me to take a look at the whole person, looking at the symptoms individually of a person, and then looking at medications and looking to see if there's things that maybe we can dissect out by just looking at this in a little bit of a different way. Next slide, please. So I love this concept of health, this idea of something called salutogenesis. It's the studies of the origins of health, and it focuses on factors that support human health and well-being rather than on what causes disease. So when we look at it that way, in medicine, sometimes we get listed as a problem list for all of us when we go into healthcare on our electronic medical records, but we start to shift that language so that we can sort out who people are and how we can help them find healing within what's going on for them. Next slide, please. So I want to use this as a way to think about the diabetes part of the neuropathy. Is we look at culinary medicine as a way to blend the art of food and cooking with the science of medicine. And so this idea of teaching people how to eat, studying what are the ideas that could be helpful, and presenting those in ways that are easy to do, cost-effective, and culturally sensitive is really a wonderful way to bring health into anybody's life with it. Next slide, please. So what we would talk about is this idea of looking at food, right? So food needs to be processed sometimes, but it's these ultra processed areas. So trying to help people understand that part of it is part of what we do, since it is sometimes not known, of how we can use food as an anti-inflammatory, right? And so many things get better when our nutrition is maximized. Not perfect, but maximized. Next slide, please. And this idea of looking at what is real food, because real food grows. Next slide. So what I focus on is let's get this fiber in. This feeds the microbiome. This is the area that when I focus on looking at what do we know in medicine, it looks like a lot is going on in our microbiome. How can we do that and feed the microbiome, which seems to affect our physical, mental, and overall health? Whole grains, nuts, seeds, beans, fruits, and then fermented foods. So that's one of our educational pieces. Next slide. And then we talk about what are prebiotic foods, how to add these in. All of these feed the microbiome. Next slide. And then, my friends, the probiotics. How can we add that in? A couple times a day looks like what most researchers, since we don't know exactly which bacteria we all need, but having a range of healthy bacteria seems to support our health overall. Next slide, please. So as we look into this idea of integrative strategies for peripheral neuropathy and diabetes, you know, the medications, as we've learned, they're helpful, right? But there's not an underlying sense. Everybody's got a different reason for it. Some of it is unknown. The best evidence is probably within our literature is the alpha lipoic acid and acetylcysteine, and the acupuncture and the capsaicin, as was mentioned. The other piece of it, though, is that there are some interesting herbs. Rhodiola and berberine is not an herb, but a supplement. And then I'll show you a little bit about my friends, the mushrooms, in a minute, of thinking how those might be helpful. And this idea of the mind-body is really, really a big part of it. Anytime there's pain, there's activation of the nervous system, because the nervous system feels something is wrong. And so how can we begin to calm that down? Next slide, please. So here are the mushrooms. And these are medicinal. They're medicinal strength in the sense that they come in capsules. They can be ordered. But if you just take a look at this slide, you can see the ones I highlighted there were related to controlling the blood sugar and the microbiome for people that might have diabetes. So take a look there. And then if you look at my friend lion's mane there, it's probably that's the one we have a little bit more evidence for brain health and supporting nerves. Is there data yet? Maybe not yet, but little things are starting to come out, and there's no harm to these mushrooms when they're given the way they need to be given, or just eaten. You can cook them and add them into what you're eating. So this is the area that I'm following because there's no side effect, and the benefits looks like they could be a helpful adjunct. Next slide, please. So just to end here, this is what I mentioned, this idea of when we have pain, it changes the nervous system, then the body wants to protect itself, it becomes more focused, and then that cycle can happen. So really this is a big part of what we do, is helping reframe that, building lifestyle, finding joy in the day, so that the pain is a part of the day, but it's not the whole person and the whole experience of the day. Next slide, please. So this is our center. We have a garden outside of it, and now I will shift over to Joanna, our acupuncturist nurse.
Hello. So I'm going to talk a little bit about acupuncture. So acupuncture is over 3,000 years old. It originated in China, but it's now used all over the world. Many countries still only use Eastern or traditional medicine. So as the slide says, it's based on the concept that energy or qi flows through and around the body along meridians. There's different kinds of qi. We have the original qi, which we were born with, which we received from our parents. Green qi, which is from the food we eat, and then also qi from the air we breathe. Qi is needed for movement of blood and fluids, for protection. It protects us from illness, transformation or digestion, It's also needed for stability, prevents prolapse, and also for warming. So it's in our organs, our skin, our muscles, our chest kind of controls our breathing and our pulse, and it flows through defined channels or meridians. And it's believed that illness occurs when something blocks or disrupts the balance of qi, and acupuncture is a way to unblock or balance. Next slide, please. So there are 12 main meridians on the body, running through the body. There is 365 points on those meridians, but there's also many, many extra points on the body as well as the ear, totaling about over 2,000 points. And each point has defined therapeutic actions. The points are chosen based on the presenting TCM, or traditional Chinese medicine, diagnosis, and also point selection is based on research. So what protocols, what point combinations have been researched and proven to be effective? And for neuropathy, there's typically points used locally on the feet or the legs or the hands. And again, the goal of acupuncture is to balance everything. Next slide, please. So we do need an explanation, a Western explanation of how does acupuncture work. So most of the explanations that we have are validated by traditional blood tests or imaging, such as ultrasound or MRI. Acupuncture activates several systems in our body, including the central nervous system and the endocrine system. It elicits an anti-inflammatory response, and it triggers the release of hormones, neurotransmitters, and endorphins. So endorphins, most people have heard of, are the feel-good chemicals that produce a morphine-like effect, and they reduce pain. And there's many studies that have shown acupuncture stimulates a significant rise in several different endorphins. Neurotransmitters, neuropeptides, these are chemicals which allow nerve cells to communicate. They're involved in numerous physiological functions, and they play a key role in pain modulation, including neuropathic pain. And research, again, has shown that several, including serotonin, dopamine, and norepinephrine, are elevated after acupuncture. One common treatment, as Dr. had mentioned before, is antidepressant drugs, the SSRIs and SNRIs, and those drugs increase serotonin and norepinephrine, but they have the side effect of decreasing dopamine, and acupuncture increases all of them. And then it blocks pain signals to the brain. This is known as the gate control theory, which is similar to how a TENS works. It increases blood flow, and this can be illustrated with ultrasound using color Doppler imaging, and can be in real time as you're receiving acupuncture. You can see the blood flow is increased. It decreases inflammation. Multiple studies over the last 5 years have shown that regulating inflammation and preventing immune overreaction are among the key principles to acupuncture. And then, of course, it stimulates the body's own innate healing abilities. Next slide, please. So, specific to peripheral neuropathy, in addition to what we've already mentioned, there have been other studies specific to neuropathy that indicate acupuncture affects or mediates change via these various molecules which are present in the peripheral nerves and the spinal system, or spinal cord. Next slide, please. So there's been a lot of research. In general, the research for acupuncture and traditional medicine has grown at twice the rate of research into conventional biomedicine. And there is a mention here of an article. It's a meta-analysis, the effect of acupuncture on diabetic neuropathy, that you can look at, which shows a lot of different studies and show that most of the studies do show that acupuncture can help with neuropathy. So it's just a collection of different studies there. Next slide, please. So when acupuncture is researched, we need objective tools, not just subjective, to measure improvement. And these are a variety of different tests that are used. We can actually test the sensory and motor conduction velocity of the nerves prior and after acupuncture and see that it can help. Next slide, please. So what does acupuncture offer? It's non-invasive, except for a small little needle. There's a little illustration there, but it's actually switched. On the left is actually the hypodermic needle, and then on the right are the 20 acupuncture needles. So you can see they're hair thin. and virtually painless. No drug-related side effects. The major side effect is relaxation, so that's a good thing. It's a good adjunct treatment with Western medicine. A lot of times people stay on their Western medicines, but the doses can be reduced, and a lot of times side effects also reduced. Prevention. So prevention is always best. If you're diabetic or you're at risk for neuropathy, you may be able to avoid severe neuropathy or neuropathy altogether. And that concludes acupuncture.
Well, what a great panel. Thank you so much for having me. I'm learning a lot, as I'm sure all of you are. Today, I'll be, as a physical therapist, I'll be sharing a bit about the various roles physical therapists play in evaluating and treating those suffering with diabetic peripheral neuropathy. First and foremost, we identify risk. Risk of falling. We've been talking a lot today about chronic pain. I'll be focusing a little bit about the balance implications with neuropathy, along with some other aspects as well. But whenever there's a problem with the feeling in our feet, it's going to impact balance. And also, we'll identify risk for wounds, which is also related to the sensation and potentially loss of vascular supply with diabetic conditions. Therapists play a key role in balance and gait, of course. Physical therapists are also involved with pain management, including chronic neuropathic pain. Should problems advance, including wounds or amputation, PTs also play important roles in those areas. And we are always, of course, educating our patients. So when I meet my patient, I like to start with a good long talk. What's going on with you? What brings you here? Oftentimes the neuropathy for my patients is secondary to other problems, all of which can impact movement and balance. We'll talk about your pain. We'll talk about your fall history, if there is one, and how you are getting around and what you're doing on a daily basis. How do you enjoy spending your time? Are you working? Are you in school? Are you enjoying retirement years and recreation? We'll then, of course, take a good look at the usual PT things involving posture, joint and muscle performance, motor function, mobility, and endurance. But we'll want to be sure to focus in on a couple of key areas specifically for the person with neuropathy. Sensation, first and foremost. The sensory exam can be, for many of my patients, as simple as a light touch with a finger or a cloth to the foot. But typically with the person with neuropathy, I'll go, become more sophisticated and use monofilament testing to give me a good gauge as to the level of sensory impairment. I'm guessing many of you are familiar with these wires of varying thickness that bend when they're pressed against the skin. Utilizing those gauges, I can determine what degree of neuropathy is present and how that might impact balance and other areas. Proprioceptive testing can also be done to determine how well you can feel your body in space. And that's a little picture of that in the lower corner. And then I typically carve out a good chunk of time for balance testing. Oftentimes that comes up in my second visit, so I can really focus in on that. And that helps me determine the degree and causative factors of imbalance. I begin with functional tests, and there are several good tests that can be used. They're listed here, and they're predictive of falls. They're also reliable and sensitive enough to detect change, which is important because we're hoping for improvement in balance, and it can also detect decline over time as well. So that's nice that they're responsive to change. Then look at how the brain is using our various senses for balance processing. We take in information from our skin and joints, that's referred to as somatosensation, and our eyes and our inner ear, the vestibular apparatus. The brain can weigh that information depending on internal or external conditions. For example, if the lights go out, and then we should be using more of our somatosensation or vestibular information because we're not using our visual information. So the brain weighs that. In the case of peripheral neuropathy, we may be more dependent on our vision and our vestibular function with the loss of sensation in our feet. This information that we gain from this type of testing will drive our choice of treatments. Lastly, I look at motor function for balance. There's a normal sequence of balance strategies used when faced with some sort of perturbation. We tap into our foot and ankle muscles first, and then utilize hip strategies. And finally, if needed, we take a step. Performance for each of these can be assessed with a simple push or nudge of my patient, or if I want to be a little bit more sophisticated with that, I'll have my patient on the moving platform, harnessed, of course, for safety, and move that platform from underneath them and see how they're responding, depending on the degree of perturbation I provide. And as PTs, we're always assessing gait. There are a few common or telltale deviations in gait that show up in peripheral neuropathy. A wide base of support is very common for neuropathy or other balance disorders. For those with weakness, enough weakness that would cause foot drop, which can be the case with more advanced neuropathy, a steppage pattern is noted, raising the limb extra high to avoid a trip. A weaving calf is also quite common. So we distill all this information as therapists and come up with the best interventions to promote safe walking and improved balance. Before I elaborate on some of those treatment concepts, I do want to briefly mention that physical therapists really don't have a lot of input, or we don't address the physiologic aspect of diabetic peripheral neuropathy, as we've heard the previous panelist. As Dr. Dmashki had mentioned earlier, therapists were widely involved with using anodyne in the past in hopes of improving capillary growth around the neurons and reduction of symptoms. But this, however, turned out to be no better than sham treatment, it looks like, from research maybe a decade or two ago. But I did a simple Google search last night, and if you really would like anodyne, I think you can still find it. If you want to try it out, you can find someone to do it, but probably cash-based, because I don't believe insurance is paying for that anymore, given the research on it. Back to balance training, though, and treating our balance. Based on findings, for those with more mild symptoms, we're going to focus on maximizing what they have. Work on getting as much stimulation to the foot as possible, using bare feet, using textured insoles that can be put into the foot, and reducing visual inputs so that, again, our brain is weighing that foot input even more so. We'll work on ankles to strengthen their function for balance. So try to maximize what they have in that regard. For those with more severe neuropathy, we may need to take a more compensatory approach. We'll be sure to use as much visual input as possible. We'll focus more on hip and stepping strategies, as ankle strategies have become more insufficient. We'll assess for the most appropriate walking aids as well, discussing environmental barriers and adaptations to those barriers. Even consider wearable protective gear to reduce the likelihood of injury if there is a fall. There we go. Physical therapists do, of course, play a role in chronic pain management, and any pain beyond 12 weeks is considered chronic pain. And it is also no longer just about the nerve receptors in the limb, but the processing within the brain. The brain is highly plastic or adaptive. And in this sense, that can be a negative thing. Pain regions in the brain can expand, and neurons that process pain signals can become sensitized. Physical therapists use several strategies to reduce sensitization of those neurons within the brain and to promote activities that help downward modulate pain through descending spinal pathways. Some of those are listed here. Of course, exercise is always beneficial. There are several physiologic mechanisms by which aerobic exercise specifically can reduce chronic pain. So we're always seeking to encourage exercise with our patients with chronic pain. Lastly, physical therapists do play a role in foot and ankle support through AFOs or in-shoe orthotics or other types of devices. We oftentimes collaborate with a local orthotist or podiatrist, providing feedback and working together to get the right support for our patients. So I'm going to leave it at that and look forward to any questions.
Thank you so much, Mark, and thank you so much to all of our panelists. We really appreciate your expertise. I invite everyone to join me back on screen right now. And there have been plenty of questions that have come in, and I invite folks to continue asking those questions in the questions box of the dashboard. The first question that I wanted to raise to the group, and again, I'll let you guys decide who is best qualified to answer, or maybe it's a combination, but folks are curious how a patient can classify the degree of their muscle weakness. They're having daily activities and problems with their daily activities, and they just want to understand, what is the normal scale? Is that something that, I don't know, Dr. Dimachky, is that more maybe in your line, or is that something maybe Mark does a little bit more in trying to understand to help compensate? So just throwing it out there.
Yeah, I think both of us can do a great job answering this. I may start, and maybe Mark can jump in. But basically, I think this is a very good question. What people are asking here, the person asking, is difference between strength and function. Because in the clinic, when you come to the doctor's office, neurologists especially, we kind of push against your muscles. We measure your strength on a scale of 0 to 5. 0 is bad, you're not moving at all. 5 is super strong, you're good. And it can be a gradation in between. However, there's a little correlation. There's some correlation, but it's not as tight as what you feel in your day-to-day activities. Someone may have still the same level of strength deficit today compared to a year ago, but they come to me and saying, I'm having more trouble walking. I'm having more difficulty with balance. And these are not picked up very well on the exam. Even though it's careful, it's not that detailed enough to pick it up. So this is kind of where function does not necessarily one-to-one correlate with the changes we see on the exam. It generally correlates, but not precisely in that matter. Mark, you might have more to add from your perspective, or others. Lori, Joanna, please chime in.
Well, I would agree with that very much so. And we do utilize a 1 to 5 scale to get a gauge on particular muscle groups. But there are a number of different functional tests too. So I very much would agree with Dr. Dimachky on that. We have ways of standardizing functional strength as well. A simple one that comes to mind is what's called a 5 times 60 stand test. How long does it take you to get up out of a chair 5 times? So we're looking at assessing our patient's movement and function. Some of that's subjective as well. So we're kind of putting all that information together as we come up with a treatment plan for where we need to focus our attention as far as strengthening and how that impacts balance and how we want to address the balance as well.
Great, thank you. This question is going to be more geared towards Joanna. Joanna, does acupuncture provide only short-term pain relief, or do you think pain relief can be maintained for a longer period of time?
Both. It definitely is more significant initially. And like, for instance, when you have a couple of treatments, you might say, you know, your pain was gone all night, and then it's kind of creeping back the next day. And then when you get subsequent treatments, and we usually recommend maybe 6 weeks in a row, you still have a diminished pain, but it might, you know, not as strong as it was that first visit. Or on the other end, sometimes it's a little bit, and then, you know, after 6 visits, it's a lot more. It's kind of hard. Everybody's different to how they react to that. With acupuncture too, if somebody is not having a response, I might use e-stim, which would be like electrodes that you put onto the needles, and you give that a little electrical stimulation that's not painful. I guess it's kind of similar to a TENS unit. And sometimes that works a little bit better. So
great, thank you. Thank you so much. We have a lot of questions coming in about lion's mane. And if you guys have heard of it, if it's helpful in providing pain relief, and similarly, any concerns that folks should be cognizant of when it comes to side effects and other concerns while taking it.
Sure, yes. So this comes from some of the work of Paul Stamets. So if you look up his name, and his company is Fungi Perfecti. There are other companies out there, but his work is the one I know. The good thing about mushrooms in general is that you can take them whether you're have any immune issues. So you could be on chemotherapy, you could be post-therapy, and they don't interfere, except if somebody's on some form of immunotherapy. So, and those are some newer cancer treatments. So that's always my, important thing to say about them. But they're quite easy to use. They're not terribly expensive, and they can be taken every day. And there are studies showing some improvement. Once again, this is not, a randomized controlled trial, but there are some indications also for overall brain health.
Just to be clear, we're not talking about hallucinogenic mushrooms, just
No,
medicinal mushrooms.
we are not talking about magic mushrooms. No, we're talking about yes, these mushrooms. Yes, mushrooms are very misunderstood.
It's a good clarification. Thank you. So I think this might be a good question for everyone, maybe a little bit more directed towards Dr. Demachky and Dr. Walsh, but I welcome Mark and Joanna to kind of chime in as well. You know, when new therapies and new treatments are coming up on the market in your respective areas, how do you guys go about evaluating them? And maybe it's not you individually, but maybe more your areas. To really understand the efficacy and the safeness for a patient to consider using to control and manage their symptoms.
I think ladies first.
Oh, well, thank you. So within integrative medicine, we look for randomized controlled trials. I'm part of big listservs of physicians of every specialty, and we connect a lot to find out, what is working and what is not working. And then we look at the Punnett square. If there's no risk, then it's you can be a little bit more lenient with that. But if there is a risk, then that's something that we would look at more closely.
Yeah, I mean, it's the same approach we follow. We look at the data. Usually studies have different phases: early phase, advanced phase studies. When you have a large study that looks at how good a medication is in modulating pain, you evaluate how many patients were there, how long the treatment was. Typically, most pain studies are 2-3 month long, 4 month long. So they're short-term studies. You look at the side effects. Someone who's already got dizziness and imbalance, and one of the side effects is dizziness and imbalance as part of the study, that's more than 10%. You may try it, but you may kind of not be too excited about it. So it's just about kind of looking the medication efficacy balanced against the side effects, the comorbidities. That's the other part, because with neuropathy, sometimes it kind of makes people sad or anxious or depressed. So if you have drugs that is an antidepressant and someone who is currently depressed as part of their neuropathy and pain, you may want to lean towards the antidepressant rather than a new medication that's hot and exciting, that's an anti-seizure medication, for example, that doesn't have an antidepressant effect. So a lot goes into it. It's not just the data, the efficacy, but generally the FDA recommends or requires manufacturers or pharma company to show that there is at least 50% pain reduction, meaning the pain went down by 50% in more people that got the active drug compared to the placebo. And they look at something called the p-value, but it ends up being a big placebo effect in all studies, meaning 20 to 30% of the time, if you give someone a sugar pill, their pain will get better.
Right. That's what I was going to tag on to as well. I mean, sometimes we've downplayed the placebo effect, but my goodness, we should just celebrate it and use it. It's really wonderful.
Oh, Joanna, I think you're still on mute. At least I couldn't hear you. I just want to make sure.
I'm unmuted. Do you hear me?
I can hear you now.
Okay. So with acupuncture, that's what a lot of people say. It's just a placebo. It's definitely not, because you can look at animals. It works for animals too. So it can't be placebo, but there is some part of it that is placebo. But if it's working, if it's relieving pain, so what it is, what we label it. But acupuncture, we were saying that a lot of people have these comorbidities. Usually, depression and anxiety go hand in hand, and it is very powerful. Acupuncture is very powerful to alleviate that, which then in turn reduces the pain. So it's that vicious circle.
I can chime in. While physical therapists aren't prescribing medications, there is a lot of research done in our field as well. And there's different levels of evidence, of course, all the way from a meta-analysis, which is looking at, numerous studies and distilling what's best practice from numbers of studies, randomized controlled trials, of course, but all the way down to more anecdotal evidence. And I look and see what's working with my patients. And I learn from my patients as well, because oftentimes I'm hearing from them what's worked for them, and so I take that as value evidence as well.
Yeah, that's amazing. Well, thank you all for answering that question. I think it was very interesting to see and hear how it's all very similar regardless of which area that you're currently practicing. So that's helpful. Questions about electrical stimulation to manage pain. Who's interested in kind of tackling that? It's more a question about the efficacy of such stimulation. Don't everyone shout at once.
I'll state briefly, because this is not something that I'm using quite a lot in my particular practice, just because of the types of patients that I'm seeing. E-stim is valuable for addressing pain. We call that TENS, and there's some mechanisms by which TENS can be effective for pain management. I'll be upfront and look to my colleagues here. With regard to neurologic pain, I don't think about E-stim right off the bat when it comes to neurologic pain, but I could be needing some education myself on that. So with regard to the efficacy of E-stim and neurologic pain. So I don't know if any of the others on the panel would like to chime in on that, if you know, but I know I think about it more so for musculoskeletal pain.
I mean, there have been studies in the past that have looked at needle stimulation to reduce neuropathic pain. And these have been positive studies. What happened over the years is, I think insurance companies stopped paying for it. Therefore, this procedure is no longer as much used currently. But there's some data, old data, that shows that if you put subcutaneous needles close to the muscles or into the muscles and stimulate with low current, that you can produce an analgesic effect. Again, this is not currently available. However, if you look at the stimulation, and I did talk about that in my presentation on spinal cord stimulation, this is implanting a stimulator in the lower thoracic, upper lumbar spine. And this is after a test stimulator is put in first, and to show that it works, then people can have an implanted electrical stimulator that delivers a pain relief. But this indication is for painful diabetic neuropathy and selected for lower extremity pain because it doesn't target the upper extremities, the arms.
Great, thank you. Question on nutrition is coming in specific to B6 toxicity, which B6 is obviously a known cause of neuropathy, and obviously health and nutrition is key for all neuropathy patients regardless of their cause, but specifically for diabetes. Can you get all of your B vitamins needed from food sources, or do you have to kind of look into other areas outside of kind of the main food products?
Yeah, that's a really good question. So part of the area that I'm focusing on too is looking at soil health to human health. And when you look at soil health, some of the micronutrients are not in the soil, and that might cause some deficiency. So that could be maybe magnesium, for instance, or zinc. in general, B vitamins, if you're eating, and it also depends how you're eating. So some people are gluten-free, or they are reducing their carbs in a way that doesn't allow for the whole grain, they might become B deficient. And then there's some medications, not necessarily that B vitamin, but the proton pump inhibitors can reduce B vitamins, as can the birth control pill. So looking to see where do we need to support people, or with aging, you're not digesting as well. So there's recommendations now to take a multivitamin for older adults to support that absorption of that. So it's a little bit of talking, finding out what people are eating, and then assessing that piece of it. But you can definitely do harm with too much of anything, and so that's a good example of really getting someone to take a look at the big picture before just if you're doing regular supplementation, that shouldn't get you in any trouble. But anything above and beyond, you really want to think about it as a medicine.
It's hard to think.
Sorry, go ahead. No, go ahead, please.
Okay, so it's really hard to think of a firm threshold for a dose of vitamin B6 that's toxic. However, there have been reports in the past when patients were receiving, for the treatment of carpal tunnel syndrome, several 100 milligram dosages of vitamin B6 over a protracted period of time, months, years, whereby they develop a neuropathy that's painful and causes imbalance. I've had experience with one patient who has chemotherapy-induced neuropathy, and she felt taking high doses, a couple of 100 milligrams of vitamin B6 would be good for her. She took it for about a year. Her neuropathy progressed despite stopping the chemotherapy. It turned out B6, too much B6 was the answer in her. So generally speaking, I tell my patients, do not exceed 50 milligrams per day of vitamin B6. The amount of required daily allowance in the diet is much lesser than that. It's about a few milligrams. But if someone is really deficient or needs to take B6 to avoid toxicity in the context of neuropathy, 50 milligrams should be safe.
And there are blood tests and obviously other tests that patients can do to really hone in on each of their levels of vitamins and supplements, right, and what they should personally think of taking and adding into their regimen, because there is no same answer for any other individual. So I think that's important to also share.
And vitamin D is important.
Also true.
A lot of people are deficient in vitamin D, and that can really add to increasing the severity of the neuropathies.
That's helpful to know. Thank you. Great. Do any of your practices or anything that you personally do talk about meditation and mindfulness? Just because this webinar is kind of centered around the holistic approach, I think we'd be remiss to not kind of identify how meditation and mindfulness practices might be helpful in incorporating into one's kind of daily regimen. Does anyone have any thoughts or direct experience in their practice with these?
That one of the things I briefly kind of mentioned is something called cognitive behavioral therapy. Oftentimes, we treat patients for neuropathic pain, we have success, but sometimes we go with medication after medication, acupuncture, physical therapy, holistic medicine, and then the patient is still suffering. And then, so in that case scenario, the approach is, if you don't mind, it doesn't matter. And using the brain power with cognitive behavioral therapy to modulate pain. You know how sometimes you kind of knock your hand across the desk while you're walking and you never even notice it, but you look back and you see a cut on your hand. But other times you barely touch anything and it's kind of hurt like the dickens and your life stopped. So your mindset is different at those different times. So cognitive behavioral therapy is for you to use your brain power to modulate pain rather than be drugged up or stuck by needles or do physical therapy. Is something you can do in the comfort of your own home. That's what I have.
I couldn't agree more. And what we, we work with people to meet them where they're at in terms of, does meditation or does have to be sitting in a chair? Some of it's movement, some of it's going outside, some of it's reaching for joy. Some of it's breath. So breath is something that I always teach because it really can deactivate the autonomic nervous system, and it's easy to add it in. So using a lot of different modalities and working as a team, I find can be helpful.
Great, thank you. So we are running up to the time of the hour, and I want to be mindful of everyone's time. Last question, and we kind of alluded to some of this as a potential treatment, but cannabis. So what is everyone's thoughts on cannabis in treatments for peripheral neuropathy symptoms, regardless of the cause? Like I said, not just diabetic neuropathy, but any form of neuropathy.
Started, I guess, at the risk of getting in trouble, but hey, no, not seriously. So, of course, each state has rules and regulations about cannabis, so you have to follow those rules. Having said that, the problem with cannabis is that there's no good trial that shows you that it is effective in neuropathic pain. Having said that, there's a strong placebo effect in nerve pain, right? And with that, if you go to the legal local dispensary and you try something and it works for you, who's to question that? Your pain is better. That's kind of my philosophy about it.
I agree. That sounds just right.
I'd agree as well, and I find that for some of my patients, they've tried that and it's not helped at all, and others have found a lot of help and benefit from it. So it's really seeming like it's a personal thing. Each body is different, responds differently to that.
So one thing I will say is that there are other herbs that are, that are relaxing, that also help with mood. So I will also pursue those with people.
And I think kind of all of your answers and everything that we covered during today's program kind of highlights just the importance of that holistic approach to managing peripheral neuropathy, managing diabetic neuropathy. So again, I wanted to extend my heartfelt thanks for the four of you in providing expert content and sharing additional thoughts in today's program. For those that are still with us or that are joining us in the recorded version, thank you again for joining. We hope that you enjoyed this program. We do try our best to provide educational resources in a variety of topics on our website and in some of these programs. So again, thank you so much for trusting and relying on the Foundation for Peripheral Neuropathy to do that for you. Wanted to also thank once again Veritas Pharma for sponsoring today's program, and thank you all again. Hope you have a good rest of the day, and if anyone needs anything from us personally, feel free to use the contact information displayed here. We're always here to support you, and we thank you so much for supporting us. Have a great day, and thank you again.
Bye.
Bye-bye.
Thank you.